like my job, and I've been a mental health nurse for it's more than 40 years, so I'm not going to give my age away. September last year, I was walking my dog and she happened to pick a fight with another dog. During that fight, I intervened and I was bitten by either of the dogs, I don't know which. As a consequence of that, I contracted sepsis with quite a virulent bacteria. Essentially, went into shock, lots of organ failure, and the result of all that is what they call a quad amputation. All of my life, I've been very independent. I never felt as if I'd lose it. I always just thought, and I still do, it's something you're constantly working towards. My wife's the gardener, not me. I used to do the heavy jobs. Yeah, the carer thing is quite important. I think the big thing for Anne has always been, if I know the help's there and how to access it, then that makes me feel better already. When I was considered to be medically fit, before I was actually discharged, this rather nice man called Nadeem turned up, and he explained that he was the hospital social worker. He explained the concepts of social care. As soon as we started the assessment, it was obvious that we were also going in a direction.
What makes me proud about working within the hospital setting is having the opportunity to work with hospital OTs, physiotherapists, doctors, working with the individual to meet that individual's need collectively. Crucially, the individual is the heart of the work that we do.
The right services were put in place in a very caring way. Nadeem was the hub. Essentially, it did feel like a joined up approach.
I think Julian naturally is a confident man, and I think it was about trying to ensure that we harness that positivity that Julian has. The strategy offers us opportunity to work with individuals around their needs and promote their confidence and independence, and allows them structure and control to think about the services that they want and how they want to live independently within the community.
All the services that I need have been provided and I feel well cared for. The difference that adult social care has made is the difference between being in an institution and being miserable and being at home and being happy.
My life was a bit of a struggle. I've always wanted to do things like be out and about, meeting new people. Basically, my head was all over the place.
I started working with Shane in May 2017. His social worker in the transitions team referred him to the Knots Enabling Service. I know that Knots Enabling Service have changed Shane's pathway for the better. His social worker told me that he was planning to commission 2 days of day services for Shane. And now what we have is someone who's happy with their life, working hard, getting paid, and for those other 5 days a week not being bored, sat at home.
Ever since me and Aidan have been talking, ever since I've called him my brother, he's shown me some good skills, he's a nice lad. I can't have no one better than him, because he's quality.
I quickly found out that Shane was very good with people and his social skills were great. He always makes me laugh. He wanted to do some gardening and also he wanted to help people, which is why he did some volunteering at the community gardens. I increase a person's confidence by focusing on what strengths they do have, because I believe if you focus on things that interest someone, you're likely to get the best out of them.
I have the confidence to actually do something now in my life.
I'm proud that I've enabled someone to be able to do those things that they wouldn't necessarily be able to do before or believe that they could do. And I think that sums up what the Knots Enabling Service is about. We've changed someone's life for the better and actually made him more independent.
My passion is basically birds of prey. The best of all are my peregrines. everything you've got is all based on a bond. If you haven't got that bond, you haven't got anything worth having. When I got told that I'd got dementia, I was told that it would gradually get worse. So it meant I had to get rid of my car. I got rid of quite a few of my Falcons and what have you. Hardly anybody ever rings me up about Falcons at all, see. You can't expect it to go on forever, but anyway, it's finished with now. Mary and myself do everything that we can. We help one another. So we've said at times we'll have to have some help.
As an occupational therapist, I try to promote a person's independence. I always start off with a person-centred approach because we just want the best for the person. So I think that's quite a good thing as a therapist to work in a team that do actually promote that. When George initially came home from hospital, he did state that outdoor mobility was one of his goals.
I'd been in the house for a long time and I was quite pleased to be able to get out and have a walk.
We're live, Chair.
Thank you very much. Good morning and welcome to the committee, which is being held remotely, with the majority of members joining the meeting from their own homes. For the benefit of the broadcast, I will now ask the clerk to the committee, Noel McMenamin, to explain who is attending today and the practical arrangements for this virtual meeting. Over to you, Noel.
Thank you, Chair, and good morning, everyone. As well as Councillor Girling, the other members present in the meeting today are Councillors Martin Wright, the Vice Chair, Richard Butler, John Duddy, Kate Fowle, Liz Plant, Kevin Rostons, Stuart Wallace, Muriel Wise and Yvonne Woodhead. Healthwatch Nottingham and Nottinghamshire is represented at today's meeting by Ajanta Biswas, and Martin Gately, the Council's Health Scrutiny Lead, is also in attendance. We're joined by 3 attendees to inform our discussions on our main substantive item today. These are Kerry Adams, who's a Senior Public Health and Commissioning Manager at the County Council, Cheryl Dudley, who's General Manager for Universal and Targeted Children and Young People Services at the Nottinghamshire Healthcare Trust, and also by Vanessa Briscoe, who's the Divisional General Manager at the Trust. Today's meeting is being held in line with the requirements of the Coronavirus Act 2020. Do please bear with us if we experience any technical issues. If we do lose members from the call temporarily, then officers will seek to assist in getting them reconnected as soon as possible, hopefully without the need to halt proceedings. Officers will inform the meeting if they are unable to rectify the issue, and we may need the meeting to be paused or adjourned temporarily. During discussions, I would also ask that members refer to the agenda pack page numbers when referring to points within the papers, and to keep your microphones on mute when not addressing the committee. Thank you, Chair.
Thank you, Noel. Okay, item 1 then, minutes of last meeting held on 9th of March 2021. Anybody got any points or questions on that? No, thank you very much. Item 2, apologies for absence.
Yes, we have apologies from Councillor Kevin Greaves, who's given apologies for personal reasons, and Councillor Fowle is substituting for Councillor Greaves today. We've also had apologies from Councillor Martin. He's on other council business. We haven't had a substitute come through for Councillor Martin.
Okay, thank you. Welcome to the committee, Kate. Right, item 3, declarations of interest. Do any members or officers present have any disclosable pecuniary interest to declare? Do any members or officers present have any private interest, pecuniary or non-pecuniary, to declare? That's a no then, thank you very much. Item 4, school nurses and family teams. I welcome Kerry Adams and Cheryl Dudley to the meeting. Can I ask that you to introduce this item in more detail? I read that as it said it.
Morning. So I'm Kerry Adams, Senior Public Health and Commissioning Manager. We were asked to come to the committee basically to give an overview of the current local authority Healthy Families programme that's been commissioned by Public Health since 2017. So we've sent you through two papers. One is a briefing paper, the other one is a little bit of data around the programme itself. Just to give you a bit of background on the programme itself. So the programme's a universal programme offered to every child and family in Nottinghamshire by Nottinghamshire Healthcare Trust. All local authorities have a statutory duty to ensure that the Department of Health's Healthy Child programme is delivered to its local population. And in Nottinghamshire, this has been branded locally as the Healthy Families programme. That's delivered by 20 healthy family teams across the county. So the programme itself incorporates health visiting, school nursing, the Family Nurse Partnership and the National Childhood Measurement Programme. And whilst the programme's actually developed locally to meet local need, there are also 5 mandatory checks that have to be carried out as part of the programme, and they're done in the first 2 to 2.5 years of life. They reflect the importance of giving every child the best start in life and the basis of the first 1001 days. And you may have seen a recent paper that's been presented by central government back at the end of March around the 1001 days and the changing requirements of local authorities to meet the needs within that. So there's a tiered approach taken to delivery depending upon the level of need that's required by each family, and specialist practitioners within each healthy family team are highly skilled at identifying child and family health and wellbeing needs, many having specific skills relating to either 0 to 5s or 5 to 19s, and these are practitioners that will have historically been known as health visitors or school nurses. So in terms of I know that the specific request here was around the school-age children. So work with school-age children, they actually receive advice and support relating to both physical and emotional health and wellbeing needs from practitioners within the programme. And they provide a variety of means by which parents and young people can gain access to the service, and that includes via the advice line that's a county-wide advice line, and via digital means through texting and web-based sites, as well as the traditional one-to-one face-to-face delivery that's provided by the service. So you'll appreciate during the pandemic the service has had to adapt quite significantly, as have all services, and they've adapted their model to adhere with the regulations set by national government. But the service has continued to prioritise children, young people and families who are vulnerable or at risk of increased vulnerability, either as a result of the pandemic or for other reasons. And all aspects of the service, regardless, have continued with face-to-face visits for the most vulnerable population. So the table in point 6 of the briefing paper, so that's Appendix 1 in your pack, demonstrates the performance of our local team compared with England as a whole. And local performance is very good, so both in terms of the England average and in comparison with our statistical neighbours. We've got very good performance locally, and this has actually continued throughout the pandemic. In view of the positive performance, the authorities extended the contract for the Healthy Families programme for an additional 4 years, so that will run up until 2024. That was in part that it was because of the performance is so good, but also to maintain some level of continuity for families across the service, because they get to know their clinicians quite well, they get to know the service, and we don't want to be messing and changing with the service unnecessarily. So in Appendix 2 of your papers, you'll see an overview of the interventions that have been offered to children and families across 2020-21. We don't have full year's data for 2021 for the next year as yet, so we've presented older data. And we can see that there's a high level of need for the emotional health and wellbeing interventions, particularly amongst the 10 to 14-year-olds. So as commissioners and providers of healthcare to children and families, we have to recognise that the pandemic has had a significant impact on emotional health for families. The whole process of having a child, bringing a child up, has been completely changed throughout the pandemic, particularly for new parents who've not had that normal peer support or that network that they may have had. So as part of our contracting process, we work really closely with the Healthcare Trust to ensure that we're meeting the needs of the local population and adapting the model accordingly based on the emerging needs that we see. And we also base it on the data that we've got coming through. So over the next year, we'll be looking really closely at what's been happening as a result of the unusual year that we've had previously, and continue to work with the Trust just to respond to local need, really. So that's me. So if you've got any questions, Cheryl and Vanessa are also on the call, because whilst I can answer the questions from a commissioning and contracting perspective, they are the experts when it comes to providing the service.
Thank you very much, Kerry. Right, I've got, oh look, Martin Wright, I've got you first. You're on mute.
I'm trying to get off mute. I'm back. Thank you, Chairman. Could I ask a question or two about the service? As previously explained, it has changed slightly during COVID, like all services have changed, and particularly within health. Could I ask questions which are general, sort of pre-COVID, and hopefully when we get back to something like normal post-COVID? So can I ask firstly, what is a universal health visitor review, which takes place 5 times in the first 2.5 years of life? Can you explain to me what that is, please?
Okay, I can, but I would like Cheryl to, if she can. Are you happy to do that, Cheryl? Because she's...
I am, yes.
Yeah.
Morning, everybody. There are 5 mandated reviews. So the first review is the antenatal, and that is where we see mums 28 weeks of pregnancy and above. And basically what we do is we introduce the service to them. We do a full health needs assessment to see if there are any issues in the family, if there are any relationship concerns, how they're feeling about the baby. So this is where we introduce the service. The second contact that we have is at the birth. So within 14 days of having baby, we go out and see the mum again, and we review the health needs assessment, because it's sometimes very different before and after the birth of a baby, and there's different needs. So we review that health needs assessment, we look at mum's mental health, we look at the parent-child interaction, and we also have that opportunity to meet dad if he's around, or mum as well, mum number 2. So depending on the relationships within the family. This third contact that we have, dependent on need, obviously, if we feel that there is more need, we will see them again before the 6 to 8 week review. If there are any mental health concerns or anything like that, we will go back, or any problems with baby, any health concerns whatsoever. The next mandated review is at the 6 to 8 week review, and that's where we do a full developmental review of baby to see how they are progressing, check weights, have a look at any concerns. Again, we assess mum's mental health, we assess parent-child interaction. And then we decide on what care comes next. So sometimes if it's universal, then the next time we will see them is if mum presents with a problem or wants to contact us, we have the advice line, etc. But if there's more targeted work that needs to be done around mental health or parent-child interaction, then we will go back and do additional supportive level 1 interventions. So things like listening visits, or additional support for parenting. We also have that opportunity as well to refer them on to children's centre services, because we work very closely with children's centre services. The next mandated review that we would see would be at 8 to 12 months, and that is a full developmental review of baby to see where how they're progressing. The next thing that we would look at again is mum's mental health. And also the parent-child relationship, because we recognise that is absolutely crucial at getting little ones to where they need to be. Based on that health needs assessment, we would then decide what level of interventions that parents may need or what level of support they may need. The final contact that we would routinely have would be at 2 to 2.5, where we do a full developmental assessment of the child, again assess parental relationships, and we would then again base any referrals onward, etc., on the development. We do the ASQ, which is Ages and Stages questionnaire. So we look at the development because we want them to be ready for school and we want them to achieve the full potential. So we also do a social and emotional Ages and Stages questionnaire so that we can assess behaviours, how they're progressing, any emotional issues that we're picking up sooner rather than later, and we signpost and refer to where they need to be. We also do a full speech and language screen at this point. We're just going back at the 1 year review, we again do the Ages and Stages and the language screening so that we can refer them on, and it's all about early help, early intervention, so that we can get them ready for school and learning. Does that answer your question?
Martin, do you want to come back?
Yeah, just quickly, please, Chairman. Can I ask, is it always a health visitor who undertakes these 5 visits, or can it be delegated to another level?
For the first 3 visits, it's the health visitor. We have moved away from having a skill mix member of the team to do the 1 year review. We're moving that on to be the health visitor because of the mental health screening and the full developmental screen. The 2 to 2.5 year can be delegated because we have a really skilled team of practitioners that can take that on. But any of the targeted, where we do have health concerns, where it does need more in-depth assessment and possibly intervention, it would then be a health visitor again.
Can I just come back once more? I don't want to take all the meeting, but just to finish off on this area, 5 reviews within 2.5 years. Some taken by the health visitor, others taken to other members of the team. How are these reviews, how is the outcome of a review recorded, and who gets to see the outcome of the review other than the health visitor themselves?
What we do is we record the outcome of the review in the parent held record. So each parent has a red book, and that's where we record all the information from the development reviews. It is pre-seed in the red book because of the amount of space that we have, but there's an opportunity in there to write a plan of care if we need to. The other thing that we record it on is System 1. We have a really comprehensive health record that sits within System 1, and that is also seen by the GPs in primary care. The other thing that we can do is we can share it with, if a child's referred on into another service that is provided by Notts Healthcare Trust, so if it's occupational therapy, physiotherapy, etc., that they can also see what we do in that child's record. And also safeguarding, that's really important as well. So if there are any safeguarding concerns that we pick up, they can then see anything from the national safeguarding template, but also locally with more in-depth information.
Thank you, Cheryl. Thank you, Chairman.
Thank you.
Lovely. I've got Yvonne next, please.
Thank you, Chairman. Reading through this, and I'm on page 17, Appendix 2. Parenting. Now, you've got that at a very low figure of 3. So what does parenting mean to you, please?
Who's going to take that on?
Okay, so yeah, I've just had a look. So these are the and I'll let Cheryl dip in as and when needed, Cheryl. So these are the interventions that are the level 1 interventions that are offered by the health, specifically by the healthy family teams, and parenting programs are not part of the core program delivery for the healthy family team. So where we have parenting, that will be advice and just basic advice and support. This is predominantly for young people. So for the data here is predominantly for young people, for under 19s more so than for parents. So if at a review or at another contact, the Healthy Families teams were to identify that a family was in need of a level of parenting intervention, then they would be referred potentially into either a children's centre service or depending on the level of need, if it's a child with safeguarding needs or somewhere higher up the levels of pathway to provision, they might be referred into the county council family service for a specific parenting programme, because it's not an area that's currently delivered by this particular service as a universal service. Cheryl, did you want to add anything to that? You're on mute, Cheryl.
On mute, Cheryl.
Parenting support might be around weaning, so it might be around feeding issues, it might be very basic around giving them information. We have a digital platform called Recap, so we can prescribe information and bundles within that. So it gives parents the opportunity to access information as and when they want it from what we're looking at. The other thing that we support under parenting is support for behaviour. So we do level 1 interventions for behaviour, and we do a 6-week programme. So that's using the Solihull approach, which is an evidence-based approach to behaviour management. So they're the 2 specific areas that is around parenting that we would offer.
And just to add to that, Councillor Woodhead, you can see there that behaviour is actually listed as a separate tab further down. And I suppose the other thing just to add is that when it comes to sort of parenting, we're talking here about time limited interventions. Parenting advice around weaning, sleep, they're core business for health visitors, so they may not record it as a parenting intervention, but will be providing that advice as routine to families.
And do you actually meet in the home?
We do. Yes, we do.
You do?
We do. For the antenatal, we would see them possibly in the home if it's targeted. If it's a universal contact, they may come to a clinic if the parent wanted to. But for all the birth reviews, they would be done in the home, because we assess the home environment as well as the child's development, etc. The 6 to 8 week review would be done within a clinic setting.
Right, okay, thank you. I've got other questions, Keith, but on different subjects, so I'll come back in later on if that's okay.
Yeah, no problem at all. I've got John next then, please.
John, as in me? As in me? Yeah.
Yeah.
Oh, yes. So I've had a wonderful opportunity over the last number of weeks to look at this paper and actually to see how it works in practice, because every Wednesday I run a baby clinic where I do the 8-week checks and I do all the vaccinations with the nurses. And I had a medical student in, and I said to the medical student, I'm going to see exactly how much of this programme is actually working in practice. And we happen to have 3 or 4 mothers in with their 8-week-old babies. One went through just a classic where they had the early antenatal check, they'd had the newborn check, they'd had the 6 weeks review, and the baby was thriving and doing brilliantly, and they were going to be contacted as necessary. The second one in was a teenage mother, and I was very interested to see if the family nurse practitioner actually continued to exist in reality as opposed to just on paper, where they teenage mothers in their first pregnancy to provide early intervention, etc., and targeted intervention from a program I think originally developed in Colorado and thought to be very good at getting children school ready. And that was there, and there was a teenage mother come in and she was able to tell us all about it and how much intervention she'd had. And the third one was a baby who wasn't putting on any weight, and they'd had 2 weekly follows up from the 6-week check to check on the weight gain. So in one sort of microcosm of presentation, every aspect of the programme, as detailed by Cheryl, seemed to be working absolutely beautifully. The people who needed the intervention were getting the added care and the added intervention. The people who were doing well had the opportunity for it, but didn't necessarily need to get it in the same way. So I was very happy and impressed by that. As we go forward, I think one of the big challenges will be whether or not the financial envelope, as it puts forward, says that there's been a significant risk of reduced work capacity over the length of the contract, and therefore to streamline delivery and release capacity. That's where obviously the challenges come forward, that you don't want some of the people who don't need to be streamlined out of the capacity can actually sort of get lost. And I think one of the things that happened since 2015, 2016 was the move more towards a hub model of provision of care rather than health visitors and the like being practice-based, where they were in practices, they knew every family, they knew the name of the cat, they knew the name of the dog, they knew the name of the neighbours, they knew every social problem. And that was sort of removed to provide a more, perhaps efficient in a way, but certainly a streamlined way where you actually work from a hub and you may not be quite as closely involved with the communities which people used to be involved in going forward. And I think that's the danger, that sometimes we'll provide the necessary services, but the important things for families used to be mothers getting together, mothers being able to share their experiences, children, getting together and being able to share their experiences and share their problems and share how they deal with them. And I think a lot of that has probably been lost over the last year, but obviously the interventions are continuing to be present and there at the present moment. So from my point of view going forward, it's a case of, is streamlining likely to lose people who are not quite as strong-minded putting forward their problems? And the other thing is, most of the contacts are in-person contacts, 6-week contacts, etc. But as the child gets over 1 and gets into those school ages, a lot of it is by a questionnaire. And obviously a non-returned questionnaire or a questionnaire that's not filled in, etc., can allow people to slip through nets because they're not considered to have flagged up any concerns. And that was always one of the things when the new programme came in, how much it would be delivered, as Councillor Wood had asked, in person, in the home with the mother, and how much of it sort of slips into the remoteness of questionnaires and responses. I think all of the figures with regards to the performance are really, really good. And as I said, my only experience of it at the present moment is a really positive experience and challenging time. And I was very impressed by it. And I think in practice, it seems to be working very well. And I think it's a case of actually post 1 year's up to school age, etc., those people not be lost to questionnaires, but to look at perhaps increasing opportunities to do more face-to-face type things. But other than that, seems to be going very, very good. Thank you very much.
Thank you, Jonathan. Is there anything to answer on that, or what to say? Thank you very much.
Thank you.
Can I? Yeah, thank you. Can I just respond to that? I don't know if that.
Yeah, of course,
Add a little bit into that. So yes, thank you for your positive feedback. It's really good to hear that in practice this programme is working in the way that we've designed it with Notts Healthcare Trust to do, and it's meeting the needs of the people that it needs to meet. Basically, I think what you've identified there is a really good example of how the tiered provision works in practice. I think in terms of the post 1 year, if I take that first, children are seen for a mandated review at 2 to 2.5, and that is also a face-to-face review. And one of the things that we're starting to implement from this year onwards is going to be a targeted 3-year review. So children that are identified at 2 to 2.5 in need of additional support, for whatever reason really, or families that are in need of additional support, will have a targeted face-to-face review with the Healthy Families team at 3 years. And that's because we recognise the importance of school readiness and ensuring that children are ready to learn socially and emotionally once they get to school age. In terms of as children start to get older, one of the things that we've changed slightly, which was not historically in the model, is that families have the opportunity to contact the Healthy Families teams through a variety of means. If they use those digital means, either through Parent Line, which is a texting service for parents of under 5s, or Chat Health, which is a texting service for young people aged, I think it's 11 to 19. They can contact their school nurse. That's not where that intervention ends. So that conversation will lead to an offer of a face-to-face consultation with that family or with that young person in order to unpick some of the issues a little bit more really. So although we're using those digital means and those questionnaires, I suppose I just want to stress that that's not the end of it. We then will then go on to ensure that the needs are met and that the family are seen on a face-to-face basis. In terms of the finances are always a challenge, aren't they? And it's always an issue, and it never goes away. But what we've done with this particular programme is we've tried to adapt the finances, not looking at it on a year-by-year basis, but adopting an approach that covers the whole of the contract up until 2024. And we've factored in the current workforce as it stands, so there is no reason why we should be seeing any reduction or any streamlining of the workforce, because we've factored that funding in, and we've also factored in any NHS pay uplift that's been provided to ensure that the current workforce that we have and the current model that we have is sustainable till at least the end of the contract in 2024. Because of the change in contracting in the NHS and the integrated care system process, none of us really know what's going to happen in 2024 in terms of commissioning and procurement. So that's one to watch. But I just want to reassure you that from a financial perspective, the money is there to maintain the current provision until the end of the contract.
Lovely, thank you, Kerry. Right, Liz now, please.
Yes, thank you, Chair, and thank you, Councillor Doddy, for obviously your obviously knowing and seeing this service in practice. That was very enlightening and very interesting. I was really pleased to see that the Family Nurse Partnership is mentioned in this report, because it is an excellent service, obviously providing support for vulnerable teenage parents. I would be interested to know how many nurses in that are actually in the Family Nurse Partnership across the county. Also, in terms of school nurses, I'm not at all clear where we are with the numbers of school nurses and where they are actually based, because obviously the school nurse doesn't seem to be in primary schools any longer. So I'd like a little bit more information on numbers really there. And in terms of it was I think it was no, it wasn't Kerry, but one of your colleagues gave an in-depth discussion of the visits made with newborn babies, the 5 visits going up to 2.5, and I'm really pleased that there's a 3-year review as well, because my question was on the 2.5 to 2.5 year review that's done. If issues are picked up in terms of language development or any sort of developmental delay, and a referral is made, who follows up and ensures that actually takes place? I mean, the fact that you put a 3-year visit in now is obviously helpful, but every month is crucial at that age in terms of getting the child obviously to be school ready. And now we're actually talking about nursery ready, because most children are going into nurseries at 3, and we want to, as much as possible, make sure they're ready in terms of their development to take advantage of that. So it'd be who picks up the referrals, whether or not they happen. And also in terms of those 5 visits that are done with new parents, what if a parent doesn't show for one of those? What happens in terms of obviously somebody again checking that hasn't that hasn't taken place, and how obviously we can get that parent to to actually take up the offer. I think that's it. Thank you.
Okay.
Thanks, Liz.
Okay. So that if I can answer the question around FMP to start with, and then Cheryl, is it okay if I move to you for the information around how school nurses interact with the schools and the follow-ups? Is that okay? Yeah. So in terms of FMP, we currently have 15 whole-time equivalent family nurses. So that's 2 teams across the county, led by 2 family nurse partnership supervisors. I'm not sure if you are aware, but the majority of local authorities across the country have actually decommissioned family nurse partnership because it is a relatively expensive intervention. But locally, we've always felt that it is value for money, because we know that of the long-term outcomes that both the parents actually and the children of teenagers, so the teenagers as parents and the children of those teenagers actually benefit hugely from having a really structured, intensive programme. It enables families to get back into work, get back into education, because some of these young people that are actually still of school age when they're having their own child. And it also demonstrates, the national evidence shows us that children that have been through family nurse partnership programme often have the same outcomes of children that have not that are have older parents. So we're quite keen to continue with our family nurse partnership. I suppose the only thing to say about it is that we have now been commissioning that programme for 10 years, and we've had a lot of teenagers going through that programme with very successful outcomes. But the needs of that population have also changed over those 10 years. So we do need to think about how we might adapt the programme to meet those needs. So one of the significant areas that we recognise, and again, is in part because of the pandemic, it's brought it to the fore, but generally is the parent-infant interaction between particularly young parents and their teenagers and their children. And the family nurse partnership programme are very, very skilled at monitoring that parent-infant interaction and looking at the outcomes for families. So one of the things we are thinking about moving forward is trying to spread that skill into the Healthy Families team, so the knowledge and expertise that sits within FMP, sharing that with some of our health visitors in the Healthy Families team to enable them to also undertake a similar level of interaction with families that are needed. So we will adapt and adopt different methods within FMP, but the programme itself, I think, is here to stay, and we're very keen to continue to be able to fund that programme because we recognise how valuable it is. And I think we're probably, in Nottinghamshire, we probably now have the biggest team in the country. I can't say for sure, but certainly outside of London, we have the biggest team.
Thank you for that, Kerry. Are you happy with that, Liz, or you come back? Lovely. I've got Muriel next, please.
I haven't finished.
Oh, sorry, I thought you said you had. It's because you was on mute. Sorry, Liz.
No, I am happy with that. I once had the pleasure of attending a meeting about family nurse partnership, and there were a couple of young parents there, and I have to say their knowledge, their experience of child development was really impressive, and their interaction with it was a nearly 2-year-old toddler that obviously they had, was wonderful to see. So I'm really very supportive of that programme, and I'm just wondering if there's any information on sort of long-term outcomes of that we could have, because it'll be interesting in seeing that.
Yeah, I mean that's the kind of information that's collected nationally. They've been looking very carefully at how the family nurse partnership programme is adapted in the UK, because the difference between the UK and the American version, which is where the roots of this programme are, is that in America they don't have a universal service in the same way that we do. So they don't have a health visiting school nursing service in America. So it's quite a different set of outcomes. So the national family nurse partnership unit that is, I think it sits within Public Health England now, actually. They look at the long-term outcomes. They haven't published anything of late, but I do believe that there's still an ongoing study to look at the long-term outcomes, and once we have anything, I mean, we know locally, although it's some of it is anecdotal, some of it is based in our data, that a lot of our young people actually do go back into school, do go back on to get good jobs, go into employment, and that we aren't seeing the children of teenage parents then not being school ready. We're seeing that they are. So we do have that sort of anecdotal data locally, but it's not formally collected in a way that enables us to provide it in a meaningful way, really. But I think we are confident that it is working for our local population.
Did you want to come in on any of that, Cheryl?
Yes, just to reiterate really around the follow-up, Councillor Plant was asking how do we know that parents take up that offer, and how do we follow that up? So basically we have processes in place whereby if parents don't engage initially, we offer them 3 opportunities, and we have processes in place that identify when a parent hasn't actually followed this, the uptake of the review. So therefore we know the parents who are targeted, and really the parents that are targeted where we know that there's either safeguarding concerns, there's developmental concerns with the child, they're not school ready, etc. That's when we follow them incessantly, really. They don't get a choice. Whereas we do record reviews, and if they've not taken up the offer 3 times, we then do a record review to see if there's any history of any concerns or any reviews. So we have that's part of the processes within the team. So that gives you assurance that we do know the children and we do know the families to a degree that we can deem whether or not they're universal and they will then get the next offer of a review, or whether or not we continue to follow them up and pester, if that makes sense. The other thing is, from the point of view of the 2 to 2.5 year review, we also have an integrated review with settings, and each setting has a named practitioner that they can contact if they've got any concerns with the health or development of a child or young person. And that's part of our key performance indicators, where we have to demonstrate how many integrated reviews that we do over a period of time as well. So that again, that gives additional insurance. With regards to the school age offer, we have the NCMP, so we see children twice in school to do weights and measures. We also send information out to parents, so quite detailed information where they can look up things for themselves. We also have the recap. We've got Parent Line, and I know whilst you say we're not in primaries, if a primary contacts us, because each school and family of schools has again a named practitioner. We do go into secondaries, and really we do concentrate on secondary schools more so than the primaries. But if there is a concern in a primary school where they want us to come and do some health promotion, give some information out to parents, we will happily do that. That's not a problem at all. But our focus is secondary schools around the emotional support, the emotional health and well-being of the young people.
Thank you, Cheryl. Are you happy with that, Liz?
Just very quickly. So you say each primary school has a named practitioner. Is that a nurse?
It is. It is, yes. So all our teams are integrated teams. So basically, they are led by our Band 6 specialist practitioners. That is both school nursing and health visiting. And over the past 4 years, we've invested quite heavily in training and continuing to train Band 6 specialist practitioners for school nursing, and that's not the case in other areas. We feel that the school nursing offer is as important as the under fives offer. And what we've done is we have a competency framework that all practitioners have to follow to ensure that they have all the skills that are required to offer all the 0 to 19 interventions.
Okay, thank you very much. I've got Muriel next, please.
Oh, thank you, Chair, and thank you both for what you've said so far. And it's really encouraging that the early years work is so positive. I have to say, and I apologise for this, I don't remember having a very detailed discussion at Adult Social Care and Public Health Committee about the recommissioning of this service. It must have taken place, but I just don't remember it at all. I don't remember it being recommissioned. But my questions are more about the secondary school age group. So, for example, speaking of Gedling Borough, where I represent a district, what does the secondary school offer look like on the ground?
Am I okay to take that, Kerry?
Yeah, of course, sure. Yeah.
I've got another question.
Okay, sorry.
Yeah.
So if I take that one first, so the secondary school offer is we do secondary school appointment sessions. So where we can get into a secondary school, so each secondary school has an individual practitioner, be it a band 6 or band 5, and they have all the necessary skills around specifically really emotional health and well-being and behaviour. So therefore, we go into schools, we have send information at when they enter in year 7. We send out information to parents and how they can contact the Healthy Family team member. We have appointment clinics in there, either on a weekly or 2-weekly basis, dependent on facilities within the school. The other thing that we have started looking at and we're looking to pilot is a digital questionnaire for young people at year 9, so that we recognise that they know what their issues are, and basically we ask them to identify any health needs that they need help or support with, and we're quite visible around schools, and the staff know how to contact us and refer into the service.
Don't start the coffee stuff because it'll be too noisy.
We do. We collect referral in data with regards to where the majority of our referrals into the service come in for level 1 interventions for emotional health and well-being, behaviour, and the majority is the schools, so that we can demonstrate where those referrals come from.
Oh, thank you. If I may, Chair, just follow that up a little.
Yeah.
I just wondered how you talk about it, if you can get into the schools. Does this mean there are some academies where where a practitioner doesn't have access?
They would have access, but it's around having room to be able to deliver some appointment sessions. Sometimes that has been more difficult, obviously, with COVID and the pandemic, and that's been the main issue for this year. And what we can see with our data is quite clearly that for the first quarter of the year, we didn't have many referrals in, obviously, because of lockdown and schools closing. And as the schools started to open up, we saw quite an increase in referrals, and it's around how we deliver those interventions. So we can get into schools, but it's around we need to see those young people whilst they're in school. and it's around having that that issue between the learning and managing to see them for the health issues, and schools quite rightly prioritise the learning, and it's around vacant rooms as well, you know, space that we can have in schools. So they do accommodate us where they possibly can. However, it's been challenging. I won't lie, it has been challenging getting into schools.
Yes,
I must admit,
yes.
before you go on, Mira, I must admit, I wrote that quote down. That sent a little red flag up to me saying where we can get it. I'm concerned that your answer still says that it still leaves a red flag for me in terms of that, Cheryl.
Can I just follow that up with?
Yeah, of course.
Cheryl,
yeah, sorry, Mira.
Yes, because my experience locally is that that kind of presence is quite fragile. I'm not going into the details. I used to manage a voluntary counselling agency. We had contracts with local schools to give counselling support. One of our big issues was the culture of the school, understanding that it was no good just giving us a stationary cupboard to meet in, where staff came and went. So I just wonder if the significance of health care for youngsters is sufficiently established in our comprehensive schools, particularly, well, established in the academies, so that they give a value to the work you're doing. Because I see that there are a lot of referrals around anxiety of youngsters. I've spent about 2 years, amongst other things, trying to support a young person in a local academy with a high level of anxiety resulting from a health condition, which has kept her out of school for almost 2 years, apart from the beginning of her coming into some sessions in school. It's been a very, very long and difficult journey for her. The resources of CAMS have been non-existent, and the main support that her family has had in terms of counselling has come from a local small agency called We Are Here. They've had no support, and they're a sensible family who've come at this in a very even-handed way. They've struggled all the time to get any substantial support for her around her anxiety. It's been very patchy, and I just wondered if, given the long-term nature of this contract, whether it would be useful in 22 to have a substantial review of how the offer in comprehensive schools is working, to see if we're getting the pitch of resourcing right, because there's a balance between parents getting the information and the young people having the confidence to access support, and all the issues around youngsters having the confidence in someone they know. When there was a school nurse in our local comprehensive where I was a governor, the youngsters got to know her, knew when she was in school, and made their way to her on a regular basis. And I think it just seems to me that we've lost that consistent presence in schools. We've lost the consistent presence of a health specialist in special schools, even in the district I serve. I just wonder if we're getting, I think we need to perhaps review the commissioning of this area of work for the remaining contract. Thank you.
Shall I pick that up, Chair? Is that I'll pick that up, Chair. So yes, that's definitely, Councillor Vice, that's definitely something we can look at moving forward for the next year of the contract, to have do some deep dive into our secondary school offer. I think what has changed historically over the years is that there are now additional services that weren't in existence probably 5 or 10 years ago. So we have the primary mental health workers, for example, that work in secondary schools, and there's quite a lot of interaction between our Healthy Families programme and primary mental health workers in secondary schools, where they might discuss cases, and it may not always be appropriate that the school nurse is the most highly skilled person to work with that family. So we do have different offers now that we probably didn't have before. We do have Couth online counselling, for example, that is relatively new, that we can signpost young people to, and then they can make a decision about whether or not they want to see their school nurse. But I suppose it's about whether or not the school nurse is still the most appropriate person for that young person to see, because I think we're also talking about a time when the school nurse was pretty much the only health provision that was outside of school that went into school. And now that's changed quite significantly. But I think you're absolutely right. We do need to have a look at that over the next 12 months. And one of the joys of working so closely with Notts Healthcare is that we do have at the moment a monthly collaborative meeting where we look at how we're going to amend the model for the remaining years of the contract. So it's certainly within our gift to do that.
Thank you. And in the meantime, I just wonder if the information you've just mentioned does get out to the young people, particularly with the newer innovative resources that you've developed.
Yeah,
I just wonder if that is being effectively communicated.
It does, in the sense that we commission a website called Health for Teens that is promoted in schools, and Health for Teens is specifically for young people, and it has a Nottinghamshire site on it. So it's a national website but has a local site within it that provides all of that information. And if a young person contacts the service at all through Chat Health or via their school, because the school can still contact the service on their behalf. It's often, it might not be parents that do it on behalf of a teenager, but it can be other people. Then we can, in the same way as we provide information to parents, we can provide the same information to young people within the secondary schools. But we can certainly do a deeper look at that and just see how we are how we're communicating the information and making sure that people are getting what they need.
Just to give additional assurance, each secondary school has the same named practitioner that goes in on a regular basis. And like you were saying, it's sometimes about the opportunity or the rooms that you're given that hampers us a little bit, really, to be more visible in there.
Yeah. Thank you. Thank you both very much.
Thank you.
Thanks very much, Muriel. Stuart.
Thank you. I think many of the questions I would have asked have been dealt with. I, like John, had the opportunity a couple of years ago of going out with the Healthy Families to a pregnant mother, age 17. With the necessary support from the team, and I sat there in the corner, very quiet, and I found it quite impressive, the support being handed over. So again, that's just another big tick for you. My question is more on, we have a number of different organisations within the teams that you've got, all seeing children at different times. But every so often, some children just disappear. The parents and the children just go. So what do we do in order to be able to try and track people round who actually need to be sort of tracked and then given the support? That's the first one. And the second is that many times people will see something, not quite sure whether they should, couldn't, etc. So how do we filter down data information of what all the people are seeing, that we need to be more concentrating of some of our the projects we're doing, concentrating on the child, the mother, the family, or the supporting? And just one which you can answer very quickly. When you say behaviour plan, just tell me what behaviour plan means. I've got a vision what it means, but that might not be the same vision that you've got. Thank you.
Thanks, Stuart. You're going to take that home, Kerry?
Yeah, I can do. So thank you, Councillor Wallace. I think I remember you coming out to see the young lady in the Family Nurse Partnership Programme, and thanks for your comments on that. In terms of children that disappear, I suppose the thing to say there is that if somebody is determined that they're going to go somewhere and they're not going to be contacted and they're not going to be tracked, then it's very difficult. I mean, lots of organisations have the same issues with that. If children and families move out of area, there's a really good system in place whereby we do get to know somehow which area the families have moved to, and if they're a family that there are concerns about, then there will be direct conversations and direct contact between our services locally and the services that they're moving into. If they're a universal family, then any children that transfer out of area will be there'll be a transfer of records over to the new local authority area. So wherever possible, our clinicians will make sure that all information that needs to be provided is provided to whichever area that child goes to. You're absolutely right in saying that sometimes we don't know where children go to. And I can't tell you the details of the information of how it works. It just seemed to, but more often than not, families will register with a GP in whichever area they go to. Once they register with that GP, then they are automatically registered on the NHS system, and then somehow I don't know how it happens. Somehow we do get to find out if they've gone to a particular area, because their universal services where they've registered with the GP will know that they're a new transfer into the area, and they will then know that they've come from Nottinghamshire and will contact us for the information. So there are safeguards in place, but I suppose it's that case of, if a family absolutely move, and we do get families that move from place to place to place, they are very difficult to track, but they are usually families that have additional input from additional services as well. So they may be having input from children's social care. So the Healthy Families Programme doesn't work in isolation, I suppose, is one of the other things to say. So whilst we are a programme, it is a programme in its own right, it is very closely aligned to all of the other services that we have that are there to safeguard children and safeguard families. So very close working with children's social care and other local authority systems, very close working with education, for example, where we have children with needs. So, but we can never guarantee that we will be able to track every child all of the time, because it just isn't possible. But we do, wherever possible, make sure that we keep on top of where children are, particularly our most vulnerable.
To give additional assurance, really, we've got some really robust processes in place. So with children that aren't in education, we've now got a system in place with the admissions officers that will send out to parents to say that they will be giving their information for children that aren't in education to us, so that we can contact them for any reviews, etc., any health concerns, to follow those up. And that gives parents the ability to opt out over a period of 2 weeks, and then they automatically, we get their names, contact details, etc., and then we send them some information out to how they can contact us if they've got any health concerns. We get a lot of referrals for school age immunisations via that way. The other thing is we have a missing persons process from a safeguarding perspective. So that is a robust process that we follow if a family goes missing. We're very fortunate that the public, when we send out information, they will contact us and send the letters back saying these people aren't known at this address, and that's really helpful, because the public do help us out a lot by doing that. And the other thing is, on System 1, when we have a new registration, that will flag up as a new registration into the unit that a child's moved address. So if a child moves out and they move address, it automatically flags up their new address. So that enables us to contact the service where they're moving to when we can't find them. So there are quite a few safeguards in place.
Okay, yeah, happy with that, Stuart?
Yes, I am, thank you.
Thanks very much. That brings us on to Kate then, please.
Thank you, Chair, and thank you for the information. This sounds like the work you're doing is really good, so thank you for that. Just so to give you a little bit of insight from what's happening on the ground, I'm a governor of both an infant and junior school and a secondary school in Broxtowe, and I have to be honest here and say to you that the service that they're getting isn't the same as one that's just been described by other councillors. They are really, really struggling. Now, I don't know what, I don't know which service in particular actually they're asking for and not getting, but on the ground, I think Muriel's question was a good one. I would be really interested I can see that you've got a number of interventions, particularly around anxiety, which again Muriel picked up, which worried me, because I think children out there are really struggling in terms of their mental health, and both the primary and infant and the secondary school that I'm a governor of are really, really concerned about their children in terms of their anxiety. And I'm less interested in the number of interventions, but more interested in actually impact. Actually, how are these children being helped? Because the mental health service that they're getting continues to be an absolute worry and a disappointment. I really have to be honest here. It just isn't working. It's not fit for purpose. And I know you're at the early stages of that in terms of the anxiety, but that's good. Your early intervention, the work you're doing in terms of early intervention is brilliant. We need more of that. We need to understand what works. We need to understand the impact, and it's great. But certainly the schools that I've kind of been involved with are not reporting the rather positive picture that that has been described by some of the councillors. The hidden harm one you've answered really well. Thank you for that. That's a worry, isn't it? Because a lot of the families and the children you want to get in touch with, sometimes for various reasons, they're very anxious about getting in touch with sort of any kind of authority figure. So that's kind of really helpful. I think one of the other things that I wanted to pick up with you as well is, and I'm really glad that you're working really hard with other services. That's really important, isn't it? But the children's and young people's journey here can be very complicated. It can involve an awful lot of different resources, an awful lot of different services. And when you start talking about different tiers, my heart absolutely sinks. These are children that need help. And it seems to me that sometimes, because of the way that, and I understand this is not your fault and not your doing, because of the formal way the tiers have been set up and the services have been set up, they can provide significant barriers to actually children getting the service they need, particularly if they're falling between different tiers. And when you mentioned about ICS, again, alarm bells rang to me, because I sit on one or two mental health partnership board meetings. And there is a real concern being expressed there, that particularly around children's mental health, that actually, if the ICS actually takes over more of this work, and actually it becomes more health oriented, that's going to be a complete disadvantage in terms of the more, if you like, social care, social work sort of type work that needs to be done with children. And I think that's a real worry. The shift towards health provision rather than a more integrated social care provision, which seems to be happening on the ground as far as I can see, is a real worry. So I'd be really interested to hear from what you think in terms of, I know you said we're going to have to see what happens in terms of the ICS. Really interested to see what your concerns are there. I would absolutely support Muriel's suggestion that we review the offer. I mean, and I think your assurance that actually you're flexing in terms of COVID, because clearly that's had a massive impact on children and people in schools. That's great. And I'm really kind of reassured to hear that. But I really would like to understand still if we are commissioning the right service, if we're measuring the right things instead of outcomes. And I think a review, as Muriel suggested, and I think you took on, which was good, thank you, would be really good. I think all the other questions I was going to ask have been answered. So thank you.
Okay.
Can I just, before you answer that, Kerry, I think it'd be helpful, Kate, if you speak to Kerry offline about your two schools, so she can look into them in particular. I think that'd be really helpful.
Yeah. Sure, but I was making the general point too, because what Muriel said as well, it might not just be those two schools, mightn't it? Yeah. It might be a small number. We don't know, do we? But but I'm very happy to do that. Thank you.
Yeah, I was going to say I'm really sorry to hear that they're not getting what they need, and if you can let me know, Councillor Fowle, offline where those schools are, we can certainly look into that with Cheryl and Vanessa. Yes. So that's not going to be a problem at all. In terms of the impact of interventions, I don't know if you saw Cheryl had put a little bit in Appendix 2 about basically the self-reporting following the interventions, and that children and young people that had undertaken the interventions did feel perhaps more confident and better after the intervention. It's really difficult to and I'm not making excuses here, but it is quite challenging to actually assess the impact of an intervention, because many of our public health interventions are quite long term. They're not necessarily in the here and now. So to actually, we although a young person will tell us immediately after an intervention that they found it a very positive experience and that they felt that it helped, we don't really know a year on whether or not that's made a difference. So that can be quite challenging, but we are constantly looking at how we measure impact, because we try wherever possible to move to more of a outcomes based service than a numbers-based service, because historically we used to count the number of children we'd seen. Well, that doesn't mean to say that we've seen 200 children that we've made any difference at all. So we're actually trying much more to move towards an outcomes-based service wherever possible, and we're constantly reviewing that and looking at that. In terms of the tiered provision, the tiers are not set by us nationally, so by us locally. They're national guided. That's a national set of tiers. The only thing I will say is that families are not aware of the tiers at all. So it's not, you're probably thinking in terms of there used to be a CAMS tier 1 and a CAMS tier 2. In terms of the Healthy Families programme, that's not the case. Families, the tiers are purely for the use really of the clinicians to establish how much contact, how much intervention those families need. So a family doesn't know, for example, if they're moved from we don't say to them, you've moved from a universal caseload to a universal plus caseload. That's not something that's necessarily shared, because it doesn't mean anything to them. You're absolutely right. Moving through the tiers doesn't mean anything. There's no referral process through the tiers or anything like that. It is, they're on the caseload, they're seen by the clinician, and they have their named practitioner. So that's more a way that we actually define our caseloads for our clinicians than actually the impact that it has on families. So I hope that assures you a little bit about the tiered system within this particular service. Is different within other services, but within this service that is the case. In terms of the ICS, I don't think we do know what it's going to look like in a few years' time in terms of that integrated care system. The Children and Young People's Transformation Programme has literally just been launched over the last couple of months. And the ICS has a responsibility for taking that Children and Young People's Transformation Programme that was part of the NHS long-term plan, taking that forward. As a local authority, we are fully engaged with the CCG and other partners in looking at how that crosses all boundaries. So it is very NHS focused. The transformation plan is very NHS focused, does focus very much on physical healthcare. It's a national transformation programme, but we are linked into the regional transformation board. So I sit on the regional transformation board for the Children and Young People's Services, and we are pushing wherever possible for local authority and local authority commission services to be continually. We're like a bad itch really going on about the fact that you don't forget about the children that are provided. Services are provided through local authorities. So we're trying to engage wherever possible with the ICS on how that transformation takes place. And it's my understanding that one of the areas that the Nottinghamshire ICS is potentially looking at is whether or not we should have our local Children and Young People's Transformation Board, and that will be our opportunity really to get in there and try and influence the direction of travel.
I'm going to come back, Kate.
No, just to say thank you, and you're not a bad itch, you're a good itch. Keep doing it. And if I get re-elected, I'll be a good itch too, because I am quite concerned about this. The same of the ICS in terms of the governance and the way it's operating, and the kind of particularly recent white paper. I think it is a concern in terms of the kind of early intervention and work and social care work that you've been doing. I think we've got to keep banging that drum. Otherwise, I just think it could be a retrograde step in my view. Okay, so thank you. That's very reassuring, and I'll certainly be in touch with you.
Could I just add, if that's okay, we have produced a menu of intervention for schools to offer some clarity around the interventions that we offer. And I'd be happy to share that with you, Councillor Fowle, if that would help for your schools.
Yes, please. Thank you very much. That's very helpful. Thank you.
I think that'd be helpful if you shared it to everybody. So if you send it to
Yes.
Martin Wright, and he can pass it out to everybody,
Will do.
please.
Thank you.
Will do.
Okay, thanks, Kate. We've got Richard next, please.
Thank you, Mr. Chairman. And now I must apologise for this because my landline started ringing and it cut my internet off. So you may already have asked this this question, but on page 11, there's reference to the National Child Measurement Programme, which is a sort of, well, I know it's a big important national scheme that we have to follow and we have to monitor. So how does it work? What action's been taken regarding children who are perhaps found to be overweight or underweight? Because we do hear and read a lot, don't we, in general, not just in this sort of arena, but in general, about worries about diet and children being overweight in particular. And I also wonder as well whether the pandemic may also have caused a bit of a problem there, where children have been at home so much and dare I say diet or not eating as much as they should, and so on. But really just a question around the programme for the child, how it works, the child measurement programme, what we do as a follow-up. Thank you.
Okay, so I can speak a little bit about the programme and what's happened over the last 12 months, and then Cheryl, if I can move to you for how we follow up in terms of weight management for children that are identified. Is that okay?
Yeah.
Cheryl can't hear me. I'm hoping she's still there.
Yeah, I'm here.
Yeah, okay. So in terms of the National Childhood Measurement Programme, that's actually been put on pause during the pandemic because it's very much reliant upon children are weighed and measured in school basically, and the schools have been closed, so it's not been possible to access children in order to carry out National Childhood Measurement Programme. They're looking now at how that's going to be taken forward, and it may just be that it will be a select number of schools that are able to engage in that. I think it's really important to recognise the impact not only on children and families but also on schools of the pandemic, and the amount of additional work that they're having to do as a result of reopening, managing the social distancing, managing the lateral flow testing, all sorts of additional things that they now have to do that they didn't have to do 2 years ago, has put a lot of stress and pressure on schools. So I think the Department of Health have recognised this in terms of the National Childhood Measurement Programme and are not rolling it out across all schools, but there will be some schools that take part in it this year. In terms of actually how children are followed up, we have a new service that's been commissioned by Public Health called ABL. I think it's called Your Health Your Way locally, and it's a health and wellbeing service. And within that, it has a child and family weight management offer. And there's a proactive follow-up by that service for all families that are identified through NCMP as needing additional support. Now, it is an opt-in service, and NCMP, to be fair, historically has had quite bad press in the sense that a lot of families don't necessarily like it across the country, but in Nottinghamshire we have really good engagement with it, so we're confident that most of our children that need additional input, or families really, it's not so much the children, it's more the families that need that additional input, are identified. But I'm going to let Cheryl tell you how that works in practice, because I'm not in the service, and she manages that service, so she's the expert in this, if that's okay.
Yes, please.
Yeah, we live and breathe NCMP, because we do get quite a few irate parents giving us a call. So from the process perspective, once we send out the letters that identifies that the child is outside of the healthy weight range, we don't tell them the child is overweight, but we're very diplomatic and say that they're out of the healthy weight range. What we would normally do is we ask them to opt into the service, into the Your Health Your Way service, and what we're looking at doing more of, because obviously it's a choice for parents, and what we've identified is when parents do ring us up, it gives us that opportunity to do that brief intervention. When a parent rings us up, either complaining or saying that they don't think the child's outside of the healthy weight range, it gives us that opportunity to talk through and do some brief interventions around what's out there for parents to access, and if they need any additional support outside of Your Health Your Way, because that would give us the opportunity to go and see the parent and talk things through. Because whilst we say that we do sort of 6 to 8 week interventions, level 1 interventions, we also go out and see parents if we need to. It's not something that's that they have to have an intervention. We might just do a one-off visit just to talk things through, talk about the Eat Well plate, etc. The other thing that we're looking at is around interventions at 2 to 2.5, when we start to recognise that children are outside of a healthy weight range, and looking at how we can support parents going forward. So I know we're working very closely with Jenny Charles-Jones, Diane Tinkling, around how we put an intervention in there for parents where we recognise that children sort of before we hit the NCMP are looking that they're a little bit overweight, I would say. So we're also looking at that as well. And we want to get in there earlier. We want to get them before we hit the NCMP part, because it's a lot more difficult to engage them at that point than it is when they're 2 to 2.5. So that's what we're looking at the moment. Does that answer your question, Councillor Butler?
Yes, that's very helpful. In fact, I've often thought, and you mentioned about the tact and diplomacy that you and colleagues no doubt need to have when you're having a conversation with parents, and I take my hat off to you, because it must be a very difficult thing to say to a parent your child's overweight. I can only imagine what that's like. Kerry, you mentioned that although it's on hold at the moment, some schools will be coming back into the scheme. Do we know how those schools are chosen? Do we as an authority decide that, or is it sort of more of a government central thing?
In all honesty, Councillor Butler, I'd have to come back to you on that, because I'm not sure. I'd have to check with the specific commissioners of NCMP, but I can find out and let you know, unless Cheryl knows how they're going to be identified.
They've already been identified. They were given to us from a list. We had the conversation with Jenny Charles-Jones earlier on in the month, and we were given a list. How that was generated, you would need to find out, Jenny, Kerry. I'm not sure, but we've got the list already. We've approached the schools. The letters have gone out. We're already in there. We're at it.
Okay. Well, don't worry then. That's fine. You're at it. It's all under control. So no, I don't want to add to your workload. So please don't worry about it. I'm happy. Thanks.
Okay. Thank you for that, Richard. Right, I've got someone else put their hand up. Yeah, Yvonne. Right, I've got Martin next, then, please.
Thank you, Chairman. I'd like to bring the discussion back to primary schools and the role of school nurses in primary schools. Can you tell me if all school nurses are Band 6 / Band 5 specialist practitioners, or is that a supervisory grade? That's one question. We're still hearing, even in this day and age, of children arriving at school with hearing difficulties, visual issues, continence, communication problems, and even incontinence. Are these nurses who do go into primary schools, at whatever level they are they trained adequately to spot these sort of issues, and do they have the equipment to identify these sort of issues? Thank you.
Okay. So in terms of the banding of school nurses, so all specialist practitioner school nurses are band 6. They're not. It's not purely a supervisory role. They're active practitioners that will go into schools and will work with families and children and young people. In terms of the band 5 nurses are registered nurses, so they may not have the specialist practitioner qualification, but they're still registered general nurses registered by the NMC. So they again will go into schools and will work with families. In terms of vision and hearing, particularly, so the hearing checks in schools no longer take place because that's been replaced by a newborn hearing test that's undertaken at birth, which historically wasn't undertaken and now is. So schools are advised and families are advised as via their red book and via their mandated reviews if they've got any concerns about their child's hearing. So if they're noticing, for example, that the child's turning the television up or they're shouting or those kind of things, then they contact their healthy families teams, and then they're referred into specialist services for a hearing test after a visit, usually to the GP. We would normally recommend that that a family visits their general practitioner, because it could be a short-term issue with either an ear infection or a bit of glue ear or something like that. If that's ruled out, then they might be referred into the Child Hearing Assessment Centre, where a proper hearing test would be undertaken. So that's in terms of the hearing. In terms of the vision testing was historically undertaken in schools, but one of the things that we found was that there was a very large number of inappropriate referrals into specialist services, because that vision test was undertaken at the age of 5. And quite often children are not mature enough in themselves to be able to actually undertake that vision test effectively. The high street optician actually does do vision tests for 5-year-olds. So what's recommended now is that, like going to the dentist, really, children are recommended to go to the opticians on an annual basis to have their vision checked. The other issue with vision testing in school was that it could not be quality assured, because I think it was Councillor Vice mentioned earlier, some schools simply do not have the space to undertake a 6-metre vision test, and would provide very small spaces and couldn't always provide the accommodation. So vision testing was changed, and it's not a local decision. Quite a lot in most local authority areas, vision testing isn't undertaken. But again, parents are given lots of advice on how to access opticians, and should they think that there are any challenges with their children's eyes, then they'd be given the advice and support from the Healthy Families teams. In terms of continence, I'm going to leave that one with Cheryl, because we have developed a new intervention around continence, and it's quite exciting and does change the way that we used to practice. So Cheryl, can I leave that one with you? Is that okay?
Yeah, absolutely. We've developed our own continence team, so therefore we have practitioners that are highly skilled and qualified to deliver the nice guidance around the early intervention for continence. We also offer parents, where we were talking previously to Councillor Woodhead's question around early intervention and advice and support, we also offer toilet training, advice and support for the under 5s. So that's over and above this specialist continence team that we've developed. We also work closely with the integrated public health team, the specialist services for continence, and so we've got integrated pathways. So for children in special schools that require additional assessments, etc., we've got quite a streamlined service. So we should really be tackling those children that are attending at 4 and 5 with continence issues. We are seeing those much earlier and dealing with those continence issues, and we're starting, that's been going now for a year, and we've been seeing the numbers of referrals go up, and we've been seeing a lot more satisfaction from parents, obviously, and we do feel that children with additional needs from a toileting perspective are getting a far better service than they've had previously.
Okay, thank you. You happy with that, Martin?
Well, in a way, yes. It's very good to see that these services exist, but we all know there are families in all our divisions who don't know their child can't hear properly. They don't care or know that their child can't see properly, and the child does arrive at school with these problems. So what skills has the school nurse, who we're told is a registered nurse, what skills do they have to identify this or even to refer on? Thank you.
We would expect the school to have supported that child via a referral into our service. So therefore, whilst we don't routinely offer hearing or screening tests, we would support the parent and have the conversation with the parent that they need to take their child to the opticians. And whilst it might seem quite excessive, if they continue not to take their child to appointments that child needs, it then becomes a safeguarding issue, because they're not actually sorting out their child's problems. So therefore, potentially, we would say to the parent, we will refer you to MASH if you continue to not meet your child's needs. And I know that sounds really harsh, but that's reality, and we would go down that safeguarding route, Councillor Wright.
Doesn't sound harsh to me, Cheryl. That sounds exactly the right thing that we should be doing.
Good.
The welfare of that child is a priority.
Yeah, absolutely.
Yeah.
Thank you, Chairman. I'm done. Thank you.
Lovely. Thank you, John.
Yeah, thanks very much. And of course, all the language around that changed too over the last few years. Instead of a child being put down as did not attend, it's now child not brought, so that the emphasis is not on the child to attend, but on the parents to bring the child. So it's a very clear indicator of any safeguarding when we get returns like that. I did expect to get inundated with kids from schools with eye tests and ear tests when they stopped doing hearing tests and eye tests, etc. But it never materialised, and people seem to utilise High Street as they utilise everything else. So I was very surprised. Sometimes you are positively surprised when you're just not expecting it, but it didn't materialise into a deluge of people coming to the GP for hearing tests and things. I was going to bring it back to Richard Butler's point about the weight management programme, etc. And I thought we were going to slip away into the eating disorders in the 10 to 14-year-olds and the fact that anorexia remains the single biggest mental health killer of children in the country. But there is a fantastic CAMS eating disorder services in Nottingham, which every time I have interaction with it, I'm more and more impressed. I was going to bring it back to see if I could get Kerry and the team to actually take on the burden of some extra work. I was going to say that if we do have this increase in problems with regard to either obesity or weight loss, and we have a service going into school, which is a weight management service, one of the under the radar things that's occurring in increasing importance within children is childhood diabetes. And I've always sort of asked that we should make every contact count, which was always a mantra. And the idea that people are going in and being weight managed when they could potentially have a urine test or other test for diabetes, and that there's 10 children a year develop diabetic ketoacidosis and they're rushed into hospital and die, in addition to the huge numbers of diabetics type 1 and type 2 that are occurring. I think that the weight management service, I think that public health, I think that the family programme are missing out on an opportunity to pick these kids up before they end up in hospital and dying. And it's something I've put forward before to public health. It's something that I'm going to champion again if I'm back after the elections. Have you had anything, Kerry, that would actually persuade you that we're missing a trick here? We need to be picking up these diabetic kids before diabetic ketoacidosis and death, particularly as we're in contact with every single one of them.
I suppose the thing to say about that is that for me that that intervention would possibly sit better within Your Health Your Way. If we were to take it forward, it would be very challenging, I think, for the Healthy Families programme to be able to deliver that. They don't have a face-to-face consultation with every family that is identified through NCMP, for example. It might be a telephone discussion, and carrying out a urine test is quite a clinical activity, and we don't really have the schools and other areas set up to be able to do that in terms of clinical waste and those kind of things. So I think it would be a really good thing to explore, Councillor Doddy, possibly through our pre-existing public health service that isn't Healthy Families, that sees every family that's referred through. Does that make sense? It just feels like it would sit better there than sitting within the Healthy Families programme.
Yes, it is just one of those ambitious things which varies in who does what around the world.
Yeah.
And whose job it is. But I think that when we go into the ICS, these problems become shared between public health and the NHS, and then I think we've got a chance to get a solution to a problem like this. So I have to say I see a lot of positivities in the new white paper and its connection with the ICS and the work of public health to rejoin that work, which has been separated since 2012. So I think it's a great opportunity with the ICS to explore how we can pick up these undiagnosed childhood diabetics, and they are on the march, make no mistake about it.
Okay, thank you for that. I've got Yvonne next, please.
Thank you, Chairman. I'd like to ask about early years, Appendix 1, page 3 or 13, whichever number you're looking at. And it's about enhanced health by eating well and playing activity. Does anybody actually look at whether a family can afford to eat well, whether in the poverty line or below it, and what the home and family is actually like before we make this statement, please?
Who's going to do that one?
Sorry, I'm just looking for it in the paper. That's what. Okay.
It's HFT support.
So it's in the early years. Yeah, got it. Yeah.
Fourth bullet point.
Okay. So like Cheryl mentioned, an assessment of the home environment is done when a new baby comes into a family. If that family is a targeted family, it's highly likely that they will have had home visits as well, not just from the Healthy Families programme, but from potentially other services. In terms of enhancing health, eating well and playing actively, that's an aspiration that's within the Healthy Child programme for the sort of the National Department of Health Healthy Child programme, and the Healthy Families programme really do that initial assessment of a family, and then if there's some indication that that family needs some support around healthy eating and play activity, they then would probably refer that family into our children's centre services, because that's where the expertise around those two areas particularly sits, particularly around play. There's quite a lot of work going on in children's centres around food poverty at the moment, particularly with the pandemic, and there are interventions. I don't know the specifics of the interventions, but there are interventions that are delivered within children's centres to support families. We also locally have something called the Obesity Trailblazer, which does provide families with healthy eating boxes. I think they do have to pay a nominal amount for them. That's carried out in the children's centres, where families can go and pick up recipes and food for to be able to make at home. So there is quite a lot of activity that goes on. Because the Healthy Child programme isn't only delivered by Healthy Families teams, it does mean a lot of that is joint working with children's centre services. I'm not sure that answers your question, Councillor Woodhead.
I was more concerned about some of the families around me are on the poverty line. They can't afford to buy fruit and wholemeal bread. They buy the cheapest of everything and make do and manage. They do have a meal, but it's not really what you and I would call a healthy meal.
No.
And they can't afford anything else.
No, there are services that families that are struggling like that can be referred into. So that, again, it is the children's centres where they might do short courses on cooking on a budget, that kind of thing. So they'll advise families on how to make the most of what they've got. Really, obviously, the Healthy Families programme can't in itself change that situation for those families. It can only advise families on how they can make the most of what they actually are able to do. They will support them with, if they need support in terms of accessing benefits, for example, they will signpost them to the appropriate people to be able to access their benefits if their benefits are not appropriate to meet their needs. But actually, this programme doesn't have any role in actively doing anything with that information, if that makes sense.
Yeah, it does. Thank you. And do we actually link in with the district and borough councils' healthy programmes for reducing obesity in young people?
Yes. So from a public health perspective, we have very strong links with our district and borough councils. So, for example, we've just launched our Best Start strategy, and our district and borough councils are sitting on that partnership board, which is meeting for the first time this afternoon. So we're developing really strong links, and our obesity and weight management service, Your Health Your Way, also have very strong links with the district and borough councils.
So this is quite a new thing then, is it, joining up?
It's become increased. We've increased it more, I think, over the last 12 to 18 months than in the past. Yes.
Thank you. Thank you, Chairman.
Thank you. Martin, is yours a legacy hand, or do you want to ask another question?
It's just that one of my questions wasn't quite answered. It was the role of a school nurse within a primary school. We are told that they are registered nurses. They're not nursery nurses, or they're not assistants. They are fully bona fide registered nurses who don't do eye tests. They don't do hearing tests. So what do they do? Thank you.
Basically, they offer health. So if a school identifies a health promotion issue, sometimes we do some sessions around hand washing. We support the primary school, but the primary schools can refer in for early intervention for level 1 interventions. So an example being, if a parent is concerned about a child's behaviour and school is seeing that concern around the behaviour. So if I can refer you to the small steps service, that's an example that if a school or a parent is concerned about an under 11's behaviour, we can refer them into the small steps service. So we do a programme of intervention, and if we think there is a level of ADHD, ASD, we can then do that programme of intervention. Once we've done that, we can complete a getting to know me form, which will then go into the small steps service for more work and a referral into paediatricians. So it's around those low-level interventions that we can offer that might support the parent in some of the behaviours that they're experiencing with their child. So sleep, continence, general behaviour, anxieties, all of those sorts of things, anger management, all of those sorts of things are what we can offer as a parenting supportive programme. And we do that in the home. We don't actually do it in the primary school, but primary schools can refer into us. And as I say, if they wanted to do something around hand washing, something around cleanliness, we can still go in there and offer some additional support in there.
Can I come back quickly, please? That's fine. I mean, okay, you go into a primary school and you show a young boy or a young lady how to wash your hands properly, maybe how to use the toilet and a knife and fork even properly. But surely they're not qualified to address anxiety or ADHD or anything like that. You know, sure. Can you actually categorically tell me that these registered nurses, as you say, are trained to that level to be able to do that? because I really can't see it. I can see you referring it to someone else who is, and that's what's always happened. But I just cannot see that how can I put this? The nurse going into the school is a registered nurse as we know them. Are they care assistants or anything like that?
No, they've done additional courses around how to basic behaviour techniques. So the example being the Solihull training. All our staff have gone through Solihull training. That is all the levels across the whole team, and we can offer brief interventions, but they have done additional training, counsellor Wright, to be able to offer parents basic techniques in how to manage those explosive behaviours. So it's not necessarily around diagnosing. What we do is we assess what the behaviour is and what the technique the parent can use to be able to manage that behaviour and actually defuse a situation with that child, that young person. So when we talk about the very basic techniques, that's what I'm talking about. We would then, if it's escalating even worse and it's outside of our level of expertise, we would then refer them on into other services. So they have done their basic training. So what we have is we have nursery nurses that have gone through their training around the normal child, what to expect, but we do give them additional training. An example for this year that we're going to be doing is the Brazelton parent-child interaction, looking at relationships. So all our band sixes will be going through that additional training. So we're looking at the evidence base all the time and putting training in there to support that.
So just to be clear, they are nursery nurses with additional training,
no,
not SRNs, so to speak.
They are SRNs with additional training. We also have nursery nurses with additional training as well. So we adjust it. So an example being, we've around self-harm, all our SRNs, qualified staff, have had training to recognise and how to deal with self-harm. We've done additional training with our nursery nurses to recognise and do some lower level support around self-harm. So yes, they're absolutely SRNs with additional training in those specialities.
And nursery nurses with additional
And the
training.
nursery nurses, yes.
Thank you very much. Thank you.
Okay, Martin, thank you for that. Agenta.
Thank you, Chair. This is a follow-up question to what was said in the last question, or response to the last question. You said that the nurses do an initial assessment and then obviously help and provide support to the parents and so on and so forth. On the odd occasion, they refer them to other services. In case of ADHD, where exactly are they referred to? My understanding was Nottinghamshire doesn't have ADHD assessment service, unless I'm mistaken. So thank you.
Shall I take that one, Cheryl?
Yeah.
So if the health visitor or school nurse does the initial assessment and an initial piece of work with the family and suspects that a child may have ASD or ADHD, they then refer in, once that initial work has been done with the family, they would refer them into a service in the county called Small Steps. Small Steps is a service that provides a higher level intervention and a higher level of assessment with that family. Cheryl will be able to tell you more about Small Steps because she used to lead on the service than I can. And then a child then is potentially referred into community paediatrics, and community paediatric services will do a formal assessment for ASD and ADHD in partnership with Small Steps, who have already been working with that family. They'll gather the information on that child from a variety of sources, and Small Steps helps them to do that. So they'll gather the information from the GP, from the Healthy Families teams, they'll gather information from schools, and they'll also make a referral to specialist speech and language therapy, who are integral to an ASD assessment. So there is a pathway. It's not a pathway in the same sense that it was many years ago, but there is definitely a phased approach to the diagnosis of ASD and ADHD to ensure that families get the support that they need along the way. Quite a lot of children may be referred into the Small Steps service, for example, because their behaviour is representative of potential ASD and ADHD. When they've had that package of care, it could be that it isn't necessarily indicative of those conditions, and that it might be something to do with parenting or home life or environmental factors. But the pathway as it stands at the moment helps to screen that, if you like, to ensure that the right children get to the community paediatric service for a formal assessment of ASD and ADHD. So there are assessment processes in Nottinghamshire. They might just be called something slightly different to other areas potentially.
So just to clarify, there is Nottingham County, there is formal ADHD assessment which are carried out by a community pediatrician team.
Yes.
Is that what you're saying?
Yes.
Okay.
Yeah.
And that's followed through with the child going into adulthood, or you wouldn't be able to tell us that?
It's definitely. I can't tell you what happens in adulthood, but definitely through the lifetime of that child's journey through 0 to 19, and yes, it is.
Okay, you happy, agenda? Lovely. Okay.
Thank you.
Thank you so much, Kerry and Cheryl, for that. It's been quite a lot of good questions there coming at you. And thank you for, John. Is it quick? You're on mute, John. You're on mute, John.
I know. Just very quickly for Ajanta, that in the last number of months, a new adult ADHD agreed pathway between the consultants and the GPs, etc., was put into existence to catch all of the children coming off who were on those drugs. As such, that there was a big gap, Ajanta, only last year, but that gap has now been plugged. It's working well. The direct contact from us, from the consultants, with a joint protocol is all in existence. So it is now joined up, Kerry and Agenda. Yep.
Thank you.
Well, thank you. Anyway, as I was saying, well done for answering all the questions that we've been throwing at you. On page 9, it's for consider the report and also schedule further considerations. I think I've captured that the committee have concern over the school access, and I'd like us to come up with a plan on how we intend to tackle that, because just knowing it's there and not having a plan to sort of get around it, I think nothing will ever get done. So I'd like us to come back in 6 months with some sort of business plan or plan on how you're going to improve where the schools that aren't being cooperative, we can get them to be cooperative. I think I'm getting nods from the committee, so that sounds like about right. Also, a review of the service. Again, if you can come back in 6 months and tell us the findings of that review, that'd be really helpful. And also the diabetes side that Dr. Doddy raised. Again, I think we've got some concerns around that, and it'd be really helpful if we could come up with some sort of joint plan in terms of how we looking forward into sort of looking at that and prevention of the diabetes in our young children. Have I sort of captured that within the committee of what our concerns were? Muriel, I see you've got your hand up. She's gone.
Yes,
Muriel?
thank you, Chair. I just wonder if, rather than 6 months for the review of the commissioned work, whether next year might be a more realistic point at kind of the halfway stage of the commissioned work. So to review how the whole thing.
I'm happy with that. I am
you.
keen that the school access though is doubled in 6 months. Yeah.
Sure.
Yeah.
But okay. Then I'm happy with that recommendation. Is everybody else happy with that?
Can I just interject there just for a moment? I think absolutely, Councillor Vice, I think it would be unrealistic for us to come back with anything in 6 months simply because we've got the school holidays coming up, and plus schools are still not quite open in the way that we would like them to be able to make a real good assessment of that. In terms of the access, we really are looking towards support from elected members as well to help us with that in terms of how they can influence their own districts and boroughs to encourage schools to be accepting that health is as important in many cases if children are to learn effectively. So we would be looking to various committees to support us with that if possible. And just coming back to Councillor Doddy's comment, happy to come back with something about diabetes, but in all honesty, I don't think it's something that the Healthy Families programme in itself can have any influence over. I think that's possibly something for us to work with from a public health perspective, as opposed to it sitting specifically in this programme. I don't know what you think about that.
No, I accept that. Kerry, I accept that. I think from the Health Scrutiny Committee point of view, we need to get something coming in front of us in terms of how as a whole that we're going to look at that. Particularly, it's as John Doddy said about it's one of the big killers of our children.
Absolutely.
So, that's something that we need to focus on, and that needs to go part of our work programme, which I'm sure Martin Gately's putting down as we speak. So we've got some time frames there. We're all happy with that. Lovely. Thank you so much for your time. Really, it's been a really good session that has, and I really appreciate what your input into it. And
Thank you.
See you again soon.
Thank you.
Thank you. Right, thank you everybody. That takes us on to the last item then, which is the work programme. Well, we've just heard of a couple of things to go on there, which Martin will obviously do. Has anybody got any questions on the work programme? No, brilliant. Right, so before we close the meeting then, I'd just like to add my thanks really to Liz Plant and Muriel Wise, because obviously they're not standing for election, so I can wish them all the well in the future, whereas you lot I can't if you're standing against the Conservative. So thank you so much, and this is absolutely genuine, you two. Thank you so much for your input over the last 4 years. It's been invaluable. You've really sort of challenged some of the reports that's come through, which is exactly why we're here to do that. And I really appreciate all the effort and work that you've both put into that. And I wish you all the luck in the future. And I'm sure maybe we'll bump into each other at some point. And just good luck and thank you.
Thank you.
To the rest of you, well, get on with it. And I'll either see you back in after May or I won't, depending if I'm here or you are. Keep safe anyway, and if you're Conservative, good luck. If you're not, well, I don't care. Thank you very much. Thank you.